Hello, everyone. Happy to have you in this final plenary. We've had some exciting 3 days, and I think this is current event, and we're looking at development and implementation strategies that address contextual factors or rapidly evolving evidence. I'm Patrick Okwen, and I am Miranda.
Yes, I'm Miranda Langedam. I'm based in Amsterdam, University of Amsterdam, Amsterdam University Medical Center. Shall I introduce our first speaker, Patrick?
Yes, please go ahead.
Yes, well, I'm very delighted to welcome and introduce our first speaker. Our first speaker is Professor Jörg Meerpol. He is director of the Institute for Evidence in Medicine at the Medical Center and Faculty of Medicine, University of Freiburg, Germany. He is a director of Cochrane, Germany, and the Freiburg Great Center. He's a board-qualified pediatrician and a pediatric hematologist and oncologist by training. And for more than a decade, Professor Meerpol has been an active member of the GREAT Working Group and has worked as GREAT methodology advisor for several WHO expert panels and the Robert Koch Institute in Germany. Professor Meerpol will speak about adapting the evidence ecosystem to a healthcare emergency. Take it away, Jörg.
Yes, thank you. Good morning, good afternoon, good evening, everybody. I hope you can hear me okay. Excellent. So thanks, Miranda, for the kind words and introduction, and thanks to the organizers for having me today. It's a great pleasure, obviously, to be able to speak to you about the work we did in Germany. So it is, or this session is really titled Relevance and Context, and accordingly, I want to speak about the work we did in Germany in relation to the SARS-CoV-2 pandemic. As you're going to see, we were in the lucky position really to set up an evidence ecosystem and try to support through this work the pandemic management in Germany. So I think there's not much really to say because Miranda introduced myself, and those are my disclosures. There are no direct financial conflicts, I believe, except that we obviously received federal funding for this project, which I'm going to present to you. So let me take you back in time a little bit to spring 2020 in Europe and Germany specifically. Many of you will remember that that was when the first wave hit Europe. There were dramatic pictures on the media from Italy and also France. Germany was slightly less heavily affected, but nevertheless, political pressure was obviously high to act and react to the coming pandemic. And our Federal Ministry of Education and Research provided ad hoc funding in March, namely 150 million euros, so substantial funding really, not for specific projects, but rather to set up and establish a network of the 30+ university medical centers, so the tertiary centers in Germany, to strengthen the care infrastructure in Germany, thereby ensuring optimal patient care and management, but also to foster clinical research and build up infrastructure also for future pandemic management or challenges and healthcare emergency in general. So obviously this ambitious funding came with an ambitious timeline. As I said, in March 2020, it all kicked off with the launch of the network and the establishment of local task forces at university medical centers across Germany. And in late April, a call went out for project proposals. Early submissions were due in May 2020. And a few of those, I believe a dozen, were selected eventually. Many were not, obviously. And that led to the quite challenge, I'd like to say, of being asked and tasked to integrate many of the colleagues who put in proposals in that early phase and include also some of their ideas into the proposals being selected. Full proposals then were due in July 2020, and then it took the ministry and the project management agency some time to get it all going. And the first project actually started then in September 2020, and funding eventually kicked in October 2020. So what were the challenges that we were facing in Germany at the time, which we wanted to address with our evidence ecosystem? Well, obviously, with an evidence-based head-on, recommendations and political decisions should be evidence-based. I think that's obviously to this audience. However, classical evidence syntheses, namely systematic reviews, take way too long to be developed to support that in all instances. And hence, recommendations and political decisions are likely to not be evidence-based. We don't find a way as an evidence-based community to come up with evidence syntheses quickly. Thirdly, and I think that is really important in such a high pressure situation, high time pressure situation, is that coordinated and targeted knowledge translation really is key for successful implementation. And to address all these challenges, we thought that this is once a great opportunity to kind of pilot test an evidence ecosystem, but also probably the solution, or not the solution, but the way to go to support management of the pandemic in Germany. So what are the goals of project? CEOSYS stands for COVID Evidence Ecosystem. There are specific goals, obviously, in relation to the COVID-19 pandemic. It's the identification and curation of COVID-19 studies. It's the critical appraisal of the relevant studies, also to the specific context of Germany. It's then the development of living evidence syntheses, and based on that, living recommendations and guidelines. And as mentioned before, it's really the target group adapted knowledge translation strategy and implementation of those strategies that we felt is important. And there were some more general goals that we had to address as well as part of that larger network of university medicine in Germany that was established. It's really kind of setting up and facilitating networking and collaboration across university medical centers. It's the setting up and development of infrastructure and IT optimization for evidence synthesis processes, and it's to a large part training and capacity building as well. So to address those challenges and try to bring that project to life, we set up quite a large consortium. It's being, as Miranda said, being coordinated by the Institute for Evidence in Medicine here in Freiburg University, which I'm heading, and Cochrane, Germany. It includes 20 other German university medical centers. And fortunately enough, we were able, after some negotiations with the funder, to also include some external partners, which are absolutely key to our project. For one, the Scientific Institute of the AWMF, which is the umbrella organization of professional associations and organizations in Germany. And the AWMF INVI is responsible for the guideline development processes in Germany. Then members from the Institute for Journalism from University of Dortmund, members of the Cochrane Central Executive Team in London, and our colleagues from Cochrane France at University Paris Descartes. And that large consortium really set out to bring that project to life. And believe me, when we started in October 2020, it really felt like building the plane when flying it, because time pressure was on. Everybody was looking at the network university medicine and also our project specifically, and expectations were high to come up with evidence syntheses and recommendations, ideally before Christmas, which obviously was quite challenging. So this is the most complicated slide of my talk. It's really how we envisioned our evidence ecosystem. And while I understand that this might be too small to read, let me still try to take you through it. So what we actually defined upfront in our consortium were some topic areas which we felt are of high importance and relevance to address, namely diagnostic, ambulatory management and inpatient management of patients, intensive care and palliative care, and hygienic measures, in particular in the hospital setting, public health measures, and long-term and mental health consequences of the pandemic. And obviously, because of the limited resources, despite a generous funding for our project, we had a work package which is depicted at the top of, in the middle, a work package on prioritization of topics and questions in particular. Because obviously we needed to be aware of our resources. and try to also address political challenges and questions. And then there is a large part, and that's in the middle of that slide, which actually deals with the evidence synthesis and evidence management, evidence use part. So it's a work package on study identification and management. It's a work package on critical appraisal of studies. There's a fourth work package on development of living evidence syntheses, and a final one on living guidelines. And the last one on the bottom, work package 6, is our work package on knowledge translation, which again, I and our consortium believe really is key to success of this project. Then we felt that this evidence ecosystem is really an ideal setting to also work on identification of evidence gaps and development of evidence-based research recommendations. That's work package number 7 at the very bottom. And then on the right-hand side, there is a dedicated work package on meta-research, which obviously is still ongoing. But again, I believe everybody can imagine that such an evidence ecosystem is an ideal environment to conduct meta-research. Then finally, there is a work package on governance, because it is a large-scale project with a large consortium of 20 plus players and more than 150 people being involved. And the final work package is really the technical IT work package, which was tasked with setting up the infrastructure, the web platform which we're using to disseminate our results and support our work, and which also helps to link to other initiatives. So let me present and talk quickly about some of our results. This is just a snapshot of the web portal which we set up. Unfortunately, it is in German. That was one of the requirements of our funder, while they had some sympathy with being able to be accessible to non-German speaking people. Obviously, the primary focus needed to be on a German portal, and there is an English version available, which is automatically translated by Google Translate. And this portal allows obviously access to the work and the product of our CEOSYS project, and also includes obviously a description of the project, the team, and our goals. More specifically, it includes access to the Cochrane COVID-19 study register, which I believe many of you will know and probably have even used. And what we did for our project really is to integrate that study register to the development we also contributed as part of our work into our web portal. We developed the German front end to that study register, and also were eventually able to integrate a German search functionality based on the translated mesh taxonomy. So basically by now it allows also German citizens or healthcare professionals to search in German and access through a German search interface that COVID-19 register, which has been developed by Cochrane. Obviously, also the development of evidence syntheses was a key part of our project, and review production followed our prioritization list, which I briefly mentioned to you already. It relied and used standardized methodology according to Cochrane and GRADE. They were conducted by teams of information specialists, methodologists, and various clinical experts, and also lay people. And all that work was also conducted in close collaboration with the Cochrane editorial team. And because without that, obviously, it would have been a huge challenge to also get those reviews published in time for our guideline development processing. On the left-hand side, you can just see a few of the examples that have come out recently. One on ivermectin, for example, which apparently is the Cochrane review with the highest altmetric score ever. I was informed. Then there is one that we did together with Isabelle Bouton and the COVID NMA team with which we collaborated, and a third one on measures in long-term care facilities, which supported one or is supporting one of our public health guidelines. Let me come to a few words on our actually guideline activities. Our flagship, if I may say so, is the in-hospital management of COVID-19 patient guidelines. It is an evidence-based national guideline. That guideline in a kind of expert-based, consensus-based version was available early in the pandemic, but once we received funding, we linked reached out to those people and shared our resources. And members of our team of CEOSYS contributed and developed all the evidence syntheses required for the recommendations, for example, in relation to monoclonal antibodies, anticoagulation, reconvalescent plasma, remdesivir, dexamethasone, and so on and so forth. As I said, the actual recommendations are being developed by representatives of the professional organizations in Germany, but CSIS developed and supported all the evidence syntheses and developed the evidence reports that go with national guidelines in Germany. To allow us to really provide the professional organizations and the guideline group with our evidence syntheses, we relied on a fully digitalized guideline process with use of Magic and Grade Pro for the different guidelines. The tools allowed us to develop in-time evidence profiles and update them whenever required. And also evidence to decision tables obviously were used as part of the decision-making process for the respective recommendations in our guidelines. So as I said, we were aiming to really make that a living guideline, which was a challenge and something new in Germany. But I believe at the end of the day, we were successful in implementing the first living guideline in Germany. Those are three of the cornerstones of that process. So the first version came out of that guideline in February 2021. It was in part evidence-based because time was really short to come up with the respective evidence syntheses to support selective pharmacological interventions. There was a first update in May 2021 with an update of the respective evidence syntheses in our digital tools and an adaptation of recommendations based on an update of the evidence to decision table. There was a large update now just recently in September 2021 with an expansion of scope and addition of further recommendations, for example, ivermectin, IL-1 inhibitors, but also non-pharmacological interventions like ventilation techniques and others. Let me very briefly talk about a second guideline, a high-level guideline, which was developed by Eva Refis from Munich and her team. It tackles measures in school settings to prevent infection and transmission of COVID-19 in school settings that relied on a Cochrane rapid review, which was published by the team based on 26 modeling studies and a quasi-experimental studies. Again, standard processes of evidence-based guidelines were followed in Germany with use of grade methodology and grading of certainty of evidence and use of evidence to decision tables. And in this case, the team decided to use the WHO integrate framework. This guideline came in very handy at the time, namely when the new term started in February, March 2021. And because of the full set of recommendations on various measures, her minister herself presented that guideline in a press conference to media and state representatives and pupils and teachers. So let me quickly come to knowledge translation. As I said, this is really a strong focus of this project. The web portal serves to disseminate the products of CSIS. There are podcasts available and short videos which were produced in collaboration with the company, which explain the project and the guideline processes and recommendation processes. There are evidence briefs available, policy briefs, and we also held webinars to inform healthcare professionals about updates of our guidelines and changes to recommendations. Obviously, the team is active on social media, trying to spread the word further through those channels. Obviously, all this work hasn't been built on our kind of own experience and thinking. It heavily relies, and I really want to acknowledge that, on the groundbreaking work by Philippe Rabot and Isabelle Boutron from Cochrane France and the team. They published, as many of you are aware, I believe, a series in the Journal of Clinical Epidemiology in 2020, and also built that great project, COVID-NMA, which we collaborated as part of our CSIS work. I'd like to conclude with a few thoughts and lessons learned. Obviously, and I hope that has become clear, at least in part, this was and is still a huge project, and the administrative burden and the regulatory processes we have to follow are just massive, and that really kept my team, at least here in Freiburg, coordinating this project quite thin. And unfortunately, in part, we weren't even able really to contribute to the content work, which is really sad. Secondly, the grant regulations which we had to adhere to are quite restricted and complicated. and funding is short, unfortunately, only until end of this year, which is a really pity. And that also limited, and in particular, the international collaboration, because funding was mostly meant to go to German partners, at least as part of this funding scheme. And that was perceived really as a hindrance to this rather international project as it should be. But obviously, there are also some positive lessons which we learned. In particular, within the national network, the collaboration and networking was fantastic. We all learned a lot, the methodologists from the clinical practice specialists and the other way around. Collaboration with IT specialists, journalists was a great asset. The multi and interdisciplinarity worked very well for all of us. I think it was key that we early on in the project really agreed on using standardized and established methodology like Cochrane and GRADE, because that greatly facilitated the processes. We had to accept and acknowledge, and we are very grateful to members of the AWMF IMBI Institute, because that is really the link. Without all this work wouldn't have been possible to the professional organizations in Germany, which developed at the end of the day the recommendation and guidelines. And finally, while we were really ambitious in the field of knowledge translation, we had to understand and learn that this takes time. While we were able to set up the various platforms and channels in time, just to keep them going and make them known to the public in particular takes time. And it would have been great if we would have more time to really work on this. I'll close with just saying thank you again to our funder, the Ministry of the Federal Ministry of Education and Research, and the Network of University Medicine, which provides the framework for this project. And obviously the many, many people who contributed at the 20+ national and international collaborating institutions. And I'm very happy to take some questions. Thanks.
Thank you very much, Jörg, for this interesting presentation. It's very impressive how you could get all the people, all the stakeholders together and do so much in such a short time and have such a great output. We have some questions in the chat, and the first question is from Mariska Tuut from the Netherlands. And she said, well, thanks, Professor Meerpaal, for this great talk. And she asked if you could elaborate a little bit more on the journalist in the consortium. What I would like to add to that is that for those of you in the audience who are active on social media, I think in media in general, that journalists play such an important role in the pandemic in information, maybe also misinformation. So yeah, could you elaborate a little bit on the role of the journalist and the task and their, how they were involved?
Yes, absolutely, great question. So first of all, we have two journalists basically taking care of our web portal and trying to make sure that all content that goes up there, in particular whenever it is targeted to the general public or healthcare decision makers rather than health professionals, is really shaped in a way that it's understandable by lay people, that it's short, that it's succinct, and hopefully useful for individual decision making. Secondly, other journalist colleagues are basically monitoring the media and what's being put out in media, so that we are aware of what's happening there and provide us with bad and good examples of media reporting of whatever is on the news, vaccines or new drugs or ivermectin, so that we are basically able to kind of direct and tailor our work accordingly. And while that was also something new for us, working so closely with medical journalists and science journalists, I believe both sides probably learned a lot. And maybe final word to add is really that ideally there would have been closer links even with the media. It was really just a starting point and reaching out and trying to make a connection here. But again, I believe to make that even more effective, a long-term project, a long-term infrastructure, and building up relationships would have been key.
Yes, thanks. And so important to involve them from the very beginning in these projects. Yeah, thanks, Jörg. Patrick, do you have a question?
I cannot hear you, Patrick. You might still be muted.
Patrick, we cannot hear you.
So it's not only me, Miranda. You can...
No, it's not only you. No. But I don't know if Patrick can hear us.
Sorry.
Yeah, there you are.
Can you hear me now?
I can hear you. Yes.
Okay. Sorry. All right. So you have a question and a comment in the forum from Corina, and she thanks you for the really impressive work. And she also adds that all relevant players were and are committed to collaborate nationally to come to evidence-based recommendations. However, recent publications have shown that primary research on COVID-19 in Germany is rather poor, with only very few trials emerging. Do you have an explanation for this obvious gap between the generation and the synthesis of evidence in Germany? You have the screen.
Gosh, that is a challenging question, but you're absolutely right. I think the German contribution to primary research hasn't been as great as at least I personally would have hoped for. And what are the reasons for that? Well, probably, it's a complex situation, I believe. In part, probably the reason is that clinical research doesn't have the same kind of strong history and standing like in Anglo-American countries in Germany. And there has been work in the past prior to the pandemic where that picture was very similar. Germany doesn't contribute to the primary research according to its GDP and research capacity. And why that is so? Well, as I said, I think that's in part historical. There's a strong preference of basic research in Germany. A lot of funding goes into basic research and not so much funding goes into clinical research. And I think to expect that to change in a short time during the pandemic is probably not possible. Secondly, it might have to do with the incentive system in German research and environment, that it's obviously easier or often easier and quicker to publish basic research paper, and that contributes to advancing your academic career in Germany a lot. So people often prefer and don't have the expertise in clinical research. And that problem clearly has been picked up also by the media in Germany based on the study by Lars Hemkens you might be referring to. And actually just the other day I had an interview on that topic, and I have another one on Friday to the media, because it's really perceived as a limitation of the German research community. And hopefully that will be taken seriously, and hopefully some measures will take place soon to improve on the German contribution.
Okay, thank you very much. Miranda, do you want to go on with another question? There are several questions in the channel and the Q&A session.
Yes. Thanks. There is a question from Lubna Al-Ansari, and she says, brilliant work. To what extent were the policies aligned to your evidence-based recommendations? How did you manage to bridge the traditional gap between research and policy? That's also a big question.
Yeah, it's also a very big question. And the short answer is, in part, we were successful, obviously, and in other parts, not so much. It worked very well, I believe, for the clinical recommendations, because obviously the professional organizations, as I presented to you, actually were the ones developing the recommendations based on the work of CSIS and the evidence syntheses, and they carried it into the hospitals. And many of the representatives are in kind of key positions in the healthcare system. So I believe that actually worked quite well. It worked reasonably well, I believe, for example, for the recommendation on school measures, because it was just the timing was right, and the kind of perception was that that is really helpful at the time. And as far as I know, if Arefis might be in a better position to speak to that eventually, it really got implemented in part in the school setting. But there are certainly other instances where our work basically just got ignored, and because of political pressures, some political decision makers took decisions or media pushed something, and things happened that weren't really backed up by evidence in Germany. But I think that there, as I said, in part, I believe we were successful, and I think we also learned a lot how to possibly influence those decisions better in the future.
Thanks. Yes, I think we could go on for a long time on this topic, but Patrick, I think we should go to our next presenter.
Yes, sure.
Thank you very much.
Yeah, thank you, Jörg.
There are lots of questions in the Q&A, and I think what you could also do, Jörg, is to there's a possibility to respond to these questions in the Q&A, and we can still come back later to have further discussions on some of the questions when we ask you to maybe talk about some interesting questions that were posed in the Q&A session. Thank you. So Miranda.
Yes, thanks. Okay, I'm very, very pleased to introduce to you Professor Ili Akko. Professor Ili Akko is a tenured professor of medicine at the American University of Beirut in Lebanon. He leads the Division of General Internal Medicine and Geriatrics, directs the Clinical Research Institute and the GREAT Center, and co-directs the Center for Systematic Reviews of Health Policy and Systems Research. He has also a part-time appointment at the Department of Health Research Methods, Evidence and Impact at McMaster University. He serves as a guideline methodologist for a number of North American professional organizations and the WHO. Professor Ili Akko will present to us the COVID-19 Living Recommendations Map. The floor is yours, Ili.
Thank you, Miranda, for the kind introduction, and thank you for the organizing committee for the opportunity to present. I'm very delighted to be here and really honored to be on this panel with both Jörg and Susan. So the presentation, as you've mentioned today, is about e-COVID Living Recommendation Map. So I'll start with disclosures. I have no financial interest. I'm presenting on behalf of the e-COVID map team, which is led by Holger Schönemann and includes a large number of investigators and a really large number of researchers, probably more than 50 researchers working on the map. And to acknowledge the great support by the CIHR for this project. So talking about the context of the COVID-19 pandemic, so Jörg described it as the, building the plane as it's flying. I like to think about it as a stress test for the different research communities. We've been all under the stress test when we needed to perform very highly in a very short time frame with lots of expectations within very short time frames. So specifically, guideline developers were challenged to deliver recommendations that are timely, responsive to rapidly or very rapidly emerging evidence and trustworthy. So you all remember when the pandemic started, and again, as Jörg mentioned, there was a high demand for evidence from decision makers. They wanted evidence as of yesterday. So we all rushed to develop rapid guidelines. And then as soon as the rapid guidelines were out, there was more evidence and more evidence coming out. So we had to switch to the living mode. So we had to be responsive to those. And then now there's this big question about to what extent has this affected the trustworthiness of the guidelines developed, but that's a different question. But these were the expectations we were dealing with. For some reason, I can't move my slides. Could someone help me with the slides, please? Or maybe, oops. Okay, I think I can move them now. So at the same time, we talked about the stress test, but at the same time, this was an opportunity for the guideline, should say, community to accelerate innovation and field test those innovations. And this is what happened. I think what Jörg presented is a great example, but there are many other examples that you've heard about during this, this conference, including big projects on living guidelines and others. And in that context, I'll be talking about the COVID-19 Living Recommendation Map. It's an innovation that was in the works. And then when the pandemic hit, it gave the opportunity to this map to serve the cause of public health and controlling the pandemic. So in terms of the development, as I mentioned, it's an international team. You can see the map. It's from all the continents. It's inclusive of different stakeholders, including patients' representatives, the public, frontline clinicians, etc. It is based on a very detailed process that again was built as we were flying the plane. So it includes the identification and selection of guidelines, critically appraising those guidelines using standardized tool, doing the data abstraction, and then moving to the publication. So the target users are decision makers in different fields, clinical, public health and policy making, but also patients and public, as I will describe a bit later, and researchers. So this electronic platform was designed, and there was an effort made to make it easy to navigate. It is a living map in the sense that as recommendations that are already included in the map are updated, there's a process to identify the update and then integrate the update on the map, in addition to adding new recommendations that are emerging. It is freely accessible. There is no charge to access the map. And then it is linked to different guideline and evidence platforms. And then you could see the link. If you want to explore it as we're speaking, you can go to the covid19.trackmap.org. So what does it include? It includes different types of statements, what we call the formal statements, additional guidance, and good practice statement. And actually, one of the things when we talk about an opportunity, one of the things we faced as we were trying to classify the different recommendations developed with different systems, different methodologies, is how do we classify them? How do we separate from those that are formally developed from those that are not formally developed? How do I identify good practice statement? So this was a real opportunity and a challenge to come up with a taxonomy and a framework for developing these kind of statements. But in addition to those recommendations and statements, there's a growing number of what we're calling plain language recommendations that are targeting the public and the patients. And I'll give you examples a bit later. So taking you on a tour of the map. So if you go to the link, you will see that the map has different ways of giving you access, again, in the mindset of making it easily usable. So this is what's called, if you see up here, this is the recommendation map view, where on top, it's a matrix, where on top you will see the intent of the recommendation, or the type of intervention, whether it's about diagnosis, prognosis, infection control. And in the rows, you see the different types of populations that are addressed. So you could choose one of those cells. For example, you are interested in infection control, let's say in hospital setting, and then click, and there is a number of recommendations, and you could go through those. And then under effectual control, if you further click on this, you can see that there are the subtypes of intervention, if you want to call it this way, where you could further explore. So kind of making a bit more detailed to allow easier navigation. So this is the recommendation map. And then there's the recommendation list. If you look at the upper right corner, you could see that there are these two links where you click on them. So if I click on the recommendation list, you will see a long list of recommendations. So currently we are very close to 4,000 recommendations that have been identified, extracted, and published on the map. So as you can tell, it's very hard to navigate through those. So what you could do is there's these filters on the right-hand side. So these filters include things like, so first the source, which is you could choose by type of, organization that developed the guidelines, for example, the WHO, the CDC, the ECDC or others. So you click if you want, that's what you want to focus on. The other things that you could choose in terms of the filters, the publication year, the world region, if you are specifically interested in a region, the age group, which includes categories like neonates, infant, child, adolescents, and adults, coexisting conditions, intended population, which could be educational institution, governments, hospitals, etc. And then the next one is for plain language recommendation. You could say, I would like to identify recommendations that do have a plain language recommendation version. Then there are the recommendation types, whether it's a good practice or a formal recommendation, etc. Income level, recommendation intent, and then the agree score as a way to identify maybe potentially higher quality recommendations. So this is, again, a way to identify or sort recommendations. Okay, and just to show an example here, I selected the source to be the Public Health Agency of Canada. And what it does, what the website does, it sorts all of these recommendations for you from PHAC. And then if you click, let's say, on the first recommendation, this is where you dig deeper to get more detailed information. So you see here, there's the statement. And underneath the statement, you have the details about the age group, about certain resources in terms of evidence and links. You could also click, unfortunately, I don't have access to the web on the platform that I'm presenting on, but if you click on recommendations, you'll find additional information. There's a click for the ETD. So let's assume, or in cases where the organization uses the evidence decision, there's a full evidence to decision table listed. If there's a summary of finding table or an interactive summary of finding table, you could also find it there, conflicts of interest, etc. The one thing I would like to point to is the plain language recommendation. So it happens that this form recommendation, the team of the eCOVID-19 map developed a plain language recommendation for it. So this is the example. So the same recommendation, I will just take you back to show you how detailed this recommendation is, because it was intended to target professionals. So what the team working on the plain language recommendation has to disentangle the recommendation and put it into a more plain language. So you have the recommendation and then some more detailed sections about the recommendation strength, what it means. There's a section about why is it conditional, the additional information. Again, plain language summary to provide details about the benefits and harms. What you can do here specifically, because this is a recommendation about vaccination of children, about what the parents should do and how, and if they decide to talk with the health professionals, what they should talk specifically about. So this is one of the products or outputs of this map. So the plain language recommendation are being prioritized. So specific recommendation based on the need, specific request, what is of high interest in the media, different ways of prioritizing those recommendations. There's a standardized approach, including a standardized process, but also standardized tools like templates to produce those plain language recommendations. And there is this engagement of the stakeholders, particularly clinicians and citizens, in developing and reviewing those plain language recommendations. Currently, there's an effort to translate those into 13 languages. But maybe more importantly, we're taking this opportunity to do some empirical testing with some qualitative research, randomized trials being planned into for three different groups: adolescents, parents and caregiver, and the general public. Again, to better understand the optimal ways to present those plain language summaries to the intended audience. Another thing to point to when you enter this specific recommendation is this part about requesting for a development. So as you might know, a development is a specific approach to adapting guidelines. And then there's ongoing efforts to do a development with many of these recommendations in different countries: Brazil, Czech Republic, where more than 50 recommendations are being adapted for the national level, Canada for the Canadian Rheumatology Association, and South Africa, where there was a development for national recommendations. So again, this is one of the advantages of this platform, where you choose your topic, you go there, you have a list of recommendations, could compare them in terms of quality of development, in terms of the specific questions being addressed and the sources, and then you decide which one best fit your context for adaptation purposes. So to end my presentation, the COVID-19 recommendation map was designed to be a platform for practice recommendations to help practitioners, whether clinicians or public health agents or policymakers, to better deal with the pandemic and take advantage of already developed recommendations, avoid duplication of work, and build on others' work to guide decision-making. However, it's also important to say that it has been a platform for innovation when working on different projects, and public resource that people could go there and also seek ways of exploring different aspects of guidelines produced during the pandemic. So I would like to conclude by saying that we welcome partnerships. You are welcome to join our efforts to translate the public or the plain language recommendations into the different languages. If you have any feedback about the platform, you could use this email address to provide us with feedback. You could also visit the website, where there are different metrics about the use and the production within the platform. Same with our Twitter handle. And thank you so much for your attention.
Thank you very much, Eli, for this great overview of this project. Also good that, that people can have a look and provide feedback and even get involved, maybe. There's a question / comment from Lucia Kantorova, and I will read out her comment. She says, I think another challenge in developing recommendations for COVID is that a lot of them are only relevant in a certain epidemiological context, which is constantly changing. That leads to recommendations being outdated quickly, and at the same time, they can be relevant at other times or in other subgroups or in other parts of the world. So the recommendations do not only need to be framed with regards to PICO, but also context and subpopulations and possibly other factors. So when I put that comment in a question, how would the living recommendations map deal with all those changing factors, and how can you be up to date for so many factors?
Yes, thank you for the question. So the way the recommendation map deals with this is that once a recommendation or a set of recommendations are included, there's this effort and process to make sure that they are updated on the map as soon as possible after they are updated by the developing organization. So to address the need that was highlighted, obviously there has to be a living guideline process to keep up with the emerging evidence. For example, new trials coming out, changing the evidence about the effectiveness or the harms of the interventions. So that would be ideal and needed. So the map would take advantage of these living recommendations to reflect the latest version, but it also takes it to the next step, and it provides or facilitates the opportunity to take whatever recommendation developed in a specific setting and contextualize it in a different setting by providing the evidence profile, which supposedly you could use the evidence about effectiveness in different contexts in most situations, but also by providing the elements of the evidence to decision table. So you would understand what was the judgment of that panel about specific contextual factors like the cost in that setting, or the feasibility in that setting, or the acceptability, thinking about vaccine hesitancy. And then those people who are adapting would be able to say, okay, in our setting, acceptability is different in this way or that way. So they can use the original recommendation to contextualize it to their own setting.
Yeah, thanks.
Popping up in the Q&A, and this has been a very interesting presentation, Ali, and it's clearly quite engaging. I personally really like the plain language recommendations aspect with bringing clinicians and citizens reviewers, and then the translation to different languages. This is the first step towards getting this to people. And I believe that this is one of the things that would really promote behavior change and change in workplace culture. You have a series of questions that are looking at this aspect around dissemination in the forum. One from Sarah Twaddle, and she says she really likes the plain language recommendations of the red maps, but how would the members of the public actually know it is there? What have you done to raise awareness with the public? And I would also add, you can also cover another look now, which says, is the map globally accessible or not yet? So you have the screen.
Yes, thank you. Thank you for the question and for the interest in the plain language summary. So I'll start by saying this is a really big effort that is being put into this in order to facilitate the access of the public and the citizens to this. So this is definitely publicly available to anyone in any place at no cost. So this is being disseminated through presentations like this one, but also by involving stakeholder groups like consumers. So Cochrane, consumers, consumer network is being involved, but also other networks in other places, and there are efforts to engage more of those. But we would welcome any suggestions on how we could improve our efforts to disseminate this amongst the public.
Thanks. I'm just browsing to the other questions. There's a question from Yang Song, and she has a question about the sources of the recommendations. So what are the sources of the recommendations? The selected organizations, or all organizations could apply to appear on the map if they have a COVID-19 recommendation. So maybe you could also say a little bit how the project works with the organizations that have their recommendations on the map.
Yes, thank you. So that's an excellent question, and definitely we're happy to work with any organization that is interested in having its recommendations populated in the map. So we have this source part where we could add an additional source. So we had a number of processes for selecting recommendations or selecting organizations. So we do have a kind of a search process. So there's a daily search in bibliographic database in Ovid. And these are, so using searches pre-filtered by the HIRO team at McMaster University, there's a search in the gray literature on a bi-monthly basis for the major organizations like the CDC, the European CDC, PHAC, SIGN, etc. Then there's more technologically advanced, I would say, methods like using API call and web scraping on a daily basis for websites like NICE, WHO, the GIN library, and others. And then there's the personal contacts and working with partners. And many of the organizations are partners in this effort. So this includes researchers and guideline developers and Cochrane groups. So it's really a wide-ranging effort in terms of recruiting different guidelines. So the answer is yes. Partnerships are.
Okay, and I think that leads us to a final comment from Brian Alper, and you may want to connect with this, Ellie. So he says in the COVID-19 Knowledge Accelerator, and there's a link there, at tinyurl.com COCA 2020. We are defining a recommendation profile as an electronic standard for sharing a recommendation across tools and systems like what is shown in COVID-19 rec maps. And he would like to know who should be involved from COVID rec maps to contribute to the standard specifications. And he says you can email him. His email is in the Q&A. So I think we can move on to the next speaker, right, Miranda?
Yes, we can move to Susan, yes.
Okay, thank you very much, Ellie. So the next speaker is Professor Susan Mickey, and she's a professor at the University College London. Professor Mickey's research focuses on human behavior change in relation to health and the environment, and how to understand it theoretically and apply theory and evidence to intervention and policy development, evaluation and implementation. Her research, collaborating with the disciplines such as information science, environmental science, covers population change projects and the complex systems for sustainability and health. She is an investigator on the research project, including 3 addressing behavior and the COVID-19 pandemic. She has published in more than 500 journals, articles, several books, including Behavior Change Wheel. She serves as an expert advisor on UK Scientific Pandemic Insights Group on behavior science, and is a member of UK's independent SAGE, the Lancet's COVID Commission, and WHO Behavioral Insights and Science Technical Advisory Group. She is also expert advisor to Public Health England and UK Department of Health and Social Care, and is chair of the UK Food Standard Agency. I would also add that in a lot of the work that we do in Africa, we use a lot of our work, our behavior change techniques, etc. And we have actually just recently published an Cochrane Epoch systematic review that really dwells on her taxonomy of behavior change techniques, and which is looking at educational meetings like what we have at the moment, and how this can better improve health outcomes, that is a seminar, a conference, and how can this contribute subsequently to behavior change in healthcare workers. So Professor Susan Mickey, we're really, really privileged to have you on board. You have the screen.
Thank you very much. And thank you to the Scientific Committee for involving me in this panel, and Patrick, to you for those warm words. And I would be very happy to speak about what you talked about now, but actually I'm going to talk about something quite different. I'm going to take you on a little trip around behavioural science and talk about the very broad issue about how we have or haven't managed to translate scientific evidence about COVID, how to manage it during this pandemic into policy and practice. I'm not going to mention guidelines at all, and I'm just going to talk about the UK. I'm director of the Centre for Behaviour Change at UCL, a very multidisciplinary organisation. It's there for anybody who is interested in following up on it. Patrick's already mentioned my various roles, but just really to add a bit of flesh to those bones, I actually set up the behavioural part of SAGE back in 2009 during the H1N1 pandemic, and have now, for the last almost 18 months, been part of SAGE and its behavioural science advisory group. That's all on top of the very busy day job. And then I was also asked to go on to independent SAGE, which has a very different style of trying to do the same thing, which is trying to get scientific thinking and scientific evidence out into the public domain and to influence policy making. So I'm going to say something about behaviour. It's the heart of pandemic transmission, is my first message. The second is that evidence-based COVID-19 advice often failed to translate into policy and practice. And that's not just a UK observation, I know from colleagues in other countries around the world, and that there are alternative models for communicating scientific advice. So I hope this is very complementary to what has been talked about so far. Hopefully people are very aware of the role of behaviour in managing pandemics. I could also give a talk about the role of behaviour in implementing or not implementing guidelines, but again, that's another talk. And I think it's always really important to think about whose behaviours. I served on NICE, UK's National Institute of Clinical and Health Excellence for many years. It's now called something different. And we were very much thinking about who needs to do what differently and how on the basis of the evidence. So here are listed many different groups of people whose behaviour needs to change. And just think about citizens' behaviour, how do we get across the evidence about how we increase personal protective behaviours? All these ones we're so familiar with. Adherence to public health measures. And I'm going to say something about the test, trace and isolate system. Restrictions, and then vaccination uptake. Obviously vaccinations are only good as getting into people's bodies, and that depends on behaviour. So thinking about the interventions to increase those behaviours, when we're looking at the evidence for them, we have the following, and myself and colleagues describe them as BESIs. The first, behavioural interventions, environmental interventions, and obviously ventilation, whether installed as an environmental issue or whether it's human behaviour, opening windows and doors, incredibly important, social interventions, and systems interventions. Now, we and colleagues, and I'll go to the next slide here. Oh no, I won't go to the next slide, I'll just wait. But we've called them BESIs, but I'm absolutely delighted to say, since a few of us began raising this issue, the WHO have now started a whole programme of work called Public Health and Social Measures. And myself and colleagues from the BESI collaboration have been informing the research agenda for that initiative. But I just wanted to raise this question. Here's a thought experiment for you. How much of the 3.38 that should be $1 million, global funding, do you think was spent on all of the behavioral, environmental, social systems interventions versus pharmaceuticals interventions? The answer is 3 to 4%. And how many registered BESI trials versus how many pharmaceutical trials and how many conducted? Here we have from the BESI website, and this is a few weeks out of date, but it won't have changed very much. In that red box on the top, you'll see the number of drug trials, both registered and conducted. And on the bottom, you see all of the BESI trials put together. Only 15 registered, only 11 conducted. So I hope I'm making the point that we need much more research and much more evidence in this area. I mentioned there's a collaboration. You'll probably, several of you here will be very familiar with my good colleague, Jeremy Grimshaw from Canada, Paul Glazier from Australia, and Mareka Shimeris from Kenya. And we're just a group of people who are trying to get a collaboration going to really try and get more evidence generated, but as you'll see, more focus on implementation. So seeing the whole pathway from generating evidence to implementation in practice. Okay, so I just want to talk about how evidence-based advice has been given primarily in the UK through what's been called SAGE, Scientific Advisory Group in Emergencies. It has many subgroups, of which the behavioural science is one. It responds to government questions. It's rather limited in that it often takes many weeks or even months between the work being completed and the government publishing our advice. And scientific advisors are reminded that we only speak about our own area of expertise, but not comment on policy. So it's quite a narrow scientific translation type of model. I should say that it's an absolute outstanding group of scientists who are producing this evidence, both on SAGE and on the behavioural science group that I'm part of. Over 100 people on SAGE and probably about half that all told on the behavioural group. And we have world leaders from many, many different disciplines working together at weekends, in evenings, to do rapid reviews, to have expert consensus when we can't find the evidence, and to give our advice. However, what I'm going to show you is that it's been a very painful 18 months in some ways, because there are so many bits of excellent advice that just haven't landed anywhere. And I think this is a really important issue to think about. Does evidence translate into policy and practice? I'm speaking about the UK, but as I said, I don't think this country is alone. Sometimes, why not more often? I'm going to take the example of test, trace, and isolate. I'm also going to make the point we need to understand human behaviour, and we need to have mechanisms in place for this to happen. We all know, scientific advice, recommendations, guidelines don't implement themselves. So WHO has made it very clear right from the beginning, and based on good evidence, that test, trace, and isolate is an absolute cornerstone of good pandemic management. I was fortunate enough, along with colleagues, to be funded right at the beginning of the pandemic. We'd actually been funded previously in a sleeping program that got brought into life as soon as the pandemic started, of weekly surveys of around 2,000 people on behaviour, influences on behaviour. And we showed early on that even when people are symptomatic, less than half the population are isolating and less than 30% are requesting a test. We've published in many places. This was an early BMJ article. Now, how does one tackle a problem like that? And this is my little wander into behavioural science here. Many people think this is the most motivational, but we need to have a way of thinking about behaviour to know, well, is it because people don't care, or they feel they don't want to, or they don't need to? And so I commend to you this very simple but comprehensive model of behaviour, which is called COMBI. And it's at the heart of what was referred to previously the behaviour change wheel framework, which links the hub of the framework, which is this combi model, with interventions and policies. So for behavior to occur, it needs to have 3 necessary conditions. And just think about it. One has to be C, one starts with O, and one starts with M. So test yourself. First is capability, knowledge and skills, and physical capability. But unless you have the opportunity, the behavior won't occur. And you can have the capability and opportunity, but you also need the motivation. And these are linked together in a system, as you can see. And you can further subdivide it. So psychological and physical ability, the reflective, the top-down conscious decision-making, but also the automatic mechanisms, the drives, the emotions, the habits, and then opportunity, physical, but also social environment. So with this test, trace, and isolate problem, how can we understand this? And what we found out was 87% of people were willing to isolate, but those with the lowest household income were 3 times less likely to be able to self-isolate, 6 times less likely to be able to work from home. And in our research, we showed that predictors of not isolating were low income jobs and financial hardship, having caring responsibilities outside of the house, needing provisions, and needing to go out to just save a job in precarious environments. So what I'm doing here is really showing you how important the context of understanding any behavioural recommendation might be. So SAGE's advice, as you'll see here, was give financial support to those people who can't afford to isolate at home. It will be worth it many times over, and many countries have done this very well. And give tangible, practical support. Sadly, the UK hasn't done either of those things. So the most we had was £500 for 14, or then became 10 days. This is less than the minimum wage, and it isn't enough for many families to self-isolate. Throughout, our evidence-based advice was you do not punish, you do not threat, you support and you enable. But the government put a £10,000 fine for people who were found not to be self-isolating. This went against our scientific advice. And what happened, if one thinks about things in terms of complex systems, is that there were unintended consequences. There were concerned that fewer people would get tested or give their contacts or download the app. I showed you earlier that less than 30% of people in our research shows that this is happening. And an evaluation of mass testing in Liverpool showed only 8% in disadvantaged communities got testing. So that's kind of a background. And the only time, because one of the things that happened is that SAGE, unfortunately, has had a real ethos that scientists advise and politicians and policymakers decide. And that means we don't wander into policy. I've worked with government for decades and with policymakers, and I know that if you want to engage them in translating evidence into policy, you need to make it real. You need to give policy examples. We weren't allowed to do that. Here is just, I was involved in many, many papers. There are a huge number of excellent papers. And this was around one that I led on around concerns about the vaccination program potentially undermining other protective behaviours, and would this be a problem? We put out this advice and showing that it could be a problem. And so incredibly important that those giving vaccinations were reminding people that carry on with those personal protective behaviours, that it may take 2 weeks for immunity to kick in. And we also don't know, just because you're protected, whether it means that you may still be passing on an infection. And this was the only time that I managed to make such a fuss about the fact that I was hearing from people in my own experience that none of this was being talked about when you're giving your vaccination. You were just given the vaccination with nothing along those lines. And so I managed to work with NHS England, and we produced in 16 different languages downloadable animations for people's phones, posters to go up in all the vaccination centres, and leaflets with QR codes for this animation that could be sent through to people. And importantly, a script for staff giving the vaccination. Just those 3 points, nothing more. It could be done very quickly. However, I should say, this is what they look like: the leaflet, the poster, the animation. However, I asked so many people, when they got their vaccination, did you see any of this material? Nobody, whether they were people running vaccination centres, general practitioners, or people going themselves, had ever seen any of this. And I think this is tragic. A lot of work, a lot of resources were put into this. And as I said, this is the only time in the last 18 months working on SAGE that I managed to move from anything other than producing a report with some advice where we never found out what happened to it or didn't. All we saw was what happened the other end. Now, what went wrong? I don't think it was delivered, hardly at all. What I do know, I tried to set up, could we get some monitoring of this? Could we get some evaluation of it? And the answer was no. There was nobody whose job it is this. There's no resources. So in terms of this translation from one report, which just gets put out there on the web, and who knows, whether it gets to the ministers, where it gets to, and actually making a difference, there's such a gulf there, such a huge gulf. And I have other talks where I've talked a lot more about this, but in the time I have today, there isn't time to do that. But we can look at our own systems. We can also think about, is this lack of capability? Have people not got the knowledge and skills to do this? Going back to the combi model, is it lack of opportunity, that just aren't the resources, either the people or the money to do this? Or is it motivation? Is there other ideological oppositions to the evidence that's being shared with government? And I just want to finish on an alternative models for communicating scientific advice. We were obviously, the pandemic came along, everybody in their own countries were thrust into putting together something very quickly. Luckily, the UK had a tried and tested model of SAGE previously. But I was invited to join a group called Independent SAGE. This was set up by Sir David King, who is the chief scientific advisor to both the Blair government and the Brown government. And he's a passionate believer in communicating evidence direct to the public. And he was very concerned because for the first few months, SAGE didn't publish the participants, those were secret, their minutes were secret, and their reports were secret. He thought this was no way to do business. And so I, along with a dozen other people, were invited to take part in Independent SAGE. It's in no way an opposition, it's very complementary. And indeed, the many reports, I think we've probably put out about 80 reports now in Independent SAGE over the last, whatever it's been, 14 months, are very, very complementary to what SAGE puts out. But what we did when our Prime Minister stopped giving regular reports to the public, we began doing our own press conferences, press and public conferences every Friday. If you want on YouTube, you'll find us there again, 1:30 tomorrow. As you can see from the data here, we have thousands of viewers, thousands of, I think it's about 160,000 following us on Twitter now. And what we do every week, more or less in depth, is we do an update of the data. Where are we? And then we publish reports on topical issues that people are asking about. And then we hand it over to the press, to the public, to organisations. So we've had members of parliament, we have NGOs, we have city mayors coming and asking questions. And we respond in a very, I hope, accessible way. So the aim was to put scientific evidence debate into the public domain on the basis that openness and transparency leads to better understanding and better decision making. And also, our view is, and it's not shared by everybody, but our view is the responsibility of scientists and those with specialist knowledge to engage with the public and policymakers in order to ensure that science benefits all of society. And our methods, unlike on SAGE, where if we think this is a burning question that people need advice on, we can't say that. We have to wait for the government to say this is what we want advice on. We could be agile, we could be proactive, very multidisciplinary, and a small group. We also have a behavioural subgroup, very intensive. So as well as the Friday press public conferences, we meet on a Thursday evening to prepare and plan, and the behavioural group meets on a Tuesday evening. So there isn't a lot of time for real life. What with SAGE, with independent SAGE, and a research team of about 30 people, and the centre to run. Anyway, I just wanted to really put that out there. I know that we think about evidence, kind of synthesizing it, guidelines. These are all incredibly important. But, many of us have been very frustrated over the years and over the decades about the non-implementation of guidelines. And what I hope is that we can have taken this really very upsetting period in our lives as having kind of thrown up a few things, having shaken up a few things. And maybe we need to really think about parallel tracks of translating evidence into policy and into practice. And I know that our home nations, Scotland and Wales certainly, Northern Ireland to some extent, really listen to what independent SAGE have said, as do our local authorities, our local government. So there's many routes into translating evidence into policy and practice. Just acknowledging my wonderful colleagues, both on SAGE and independent SAGE, and the funders of the COVID-related research that I'm conducting at the moment. Thank you very much.
So thank you very much, Susan, for that great and thought-provoking presentation. Miranda, do you want to start with the questions, or should I go ahead?
No, go ahead, Patrick.
Okay, so John Nicholson, he says, British Isles, there appears to have been much reliance on vaccine as the way out, ignoring the need for social and behavioral change to be maintained. Does this indicate a public preference for the positivist paradigm more akin to pharmaceutical interventions?
When you look at the data of surveys that are done of the British public, indeed, if you look at the data now, there's very high support, even when they're not being mandated or advised to do things, for the kind of public protective measures that I talked about. So even now, when we've been told Freedom Day, the answer is in vaccinations, you don't need to do anything more. Most we get is some sort of weak mixed messaging. The majority of people are in favour of people wearing masks, face masks in indoor spaces. There's still a lot of support for limiting social contact and social distancing, and also for working from home when it's possible. So all the way along the pandemic, actually right from the beginning, people were wanting a lockdown before the government did. And in general, whether you ask the public, do you think there should be more or fewer restrictions than the government are imposing at any time? The tendency has been throughout that the public want more restrictions rather than less. And I think that's because they look and see, they look at the data, they listen, and they do pay attention to what's been happening in other countries and what the data is saying. And when people can see that there's a threat and know what they can do can make a difference to that threat, they're supportive, even when the government isn't in line with that way of thinking.
Yes, that is very, very, very interesting. There have so much things come to mind to compare that with the Dutch situation. But we have a question in the chat from Jacob Burgers. He is also from the Netherlands, and he says, in the Netherlands, we have a team of experts advising the government about behavioral rules and recommendations. And they need to navigate between believers and non-believers, among which scientific evidence is considered as an opinion. How could we increase the impact and acceptance of guidelines?
So there's quite a lot in that, because there's both scientific evidence and science and people's trust in that, but also guidelines specifically. So if I could say something about science and scientific evidence and trusting that, I think it very much depends on the particular country and the particular circumstances. We know that there's more trust in science than scientists than our trust in government. But where you have a general confusion, mixed messages, people in authority saying one thing and doing another, or when you've got contested science, when the majority of scientists are saying one thing, but you do get some outliers who often get picked up by the media, the mainstream media, because it makes for a good news story that sells newspapers, then this undermines trust in science and in evidence, and it allows the conspiracy theorists to make a lot of progress. I think this whole area about how do you get trust in science and trust in evidence is really important. And I think that's why the independent SAGE model is an interesting one, because we're very open. We have a website, we're very open and transparent. When we disagree with each other, say in terms of emphasis, we'll say that in a very collegiate way. When we don't know, we'll say that. And I think that helps. The issue about guidelines, most people kind of don't know what guidelines are. So I think there's a job of work to be done in terms of explaining how evidence is translated into policy and practice. I think the idea of not going with just one study, but synthesizing evidence is really important. I think that needs to be got across to the public. And then obviously the guidelines are based on those syntheses, but also bringing in the contextual information to maximize the likelihood that the guidelines will be implemented. But it's a big question, and it's like so many of these, one needs to start at school with this in terms of education and training. So throughout the lifelong education, one also needs to have good governance, and one needs to have good science writers, good people in the media that will really pick up on these things.
Yes, thanks. It's something we all do together with our our own responsibility in that. Yeah, thank you very much.
Okay, so I think we would have a couple of last questions before we close, before we move on to the closing ceremony. There is a question from Therese Christian. She's asking, do you know about any government that succeeded in supporting people in adhering to evidence-based advice?
Sorry, I missed the question.
So she's asking if you know about any governments that succeeded in supporting people in adhering to evidence-based advice.
Well, it's interesting. My son has moved to Portugal with his family, and so I've been out to Portugal a couple of times, and also looking at the data. And, the vaccination uptake, for example, in Portugal, is incredibly high. They're just running out of people to offer it to. And the use of face masks and social distancing is just routine everywhere. And there's a very high trust in government there. So it's interesting, that there will be, many countries where that's true of. Same in Southeast Asia, where there's been experience of managing the previous pandemics there. People know that things have worked, so therefore there's trust in what's being suggested to them. But I think this is a real big research agenda, because there's a big variation in terms of the extent to which there was adherence to government guidance, and a big variation in the factors influencing that. But because, as we know, scientists, there's so many confounders, there's so many variables, just comparing, Southeast Asia, Portugal, UK, there's just so many differences between these countries. But anyway, that's a whole other conference, I think.
Okay. So I think there is one last question I would just like us to maybe quickly look at. It's from Ahmed Ozair, and he's a medical student in India, and the question is a little bit opposite to what we just heard. He's talking about areas where there's actually lack of trust in government, people doubt government, and also given that there are low levels of literacy, higher education and knowledge of science methodology in their context, in low middle income countries. What are your thoughts on overcoming this kind of challenges?
Well, I mean, this is an absolutely huge area. But I think, again, I'll just go back to the Combi model. And in any setting, any population, think about to what extent is any lack of adherence to do with the fact that people don't know, what they should be doing or how to do it. Is this a knowledge and education issue? Is it that it's a motivational issue, that they don't trust what's being said to them, or that for other reasons they think it's a bad idea to do it? Or is it a question of opportunity? They do know that it's a good thing to do. They do want to do it, like isolating in the UK, but they don't have the resources, either, say, traveling to where they have to get to, or the material resources to be able to do what's being asked of them, or the social resources to give the kind of support. So I think starting with the framework, accepting that there are going to be very, very different, big differences between countries across the world. But if we can begin to think systematically using frameworks, that's going to be the most efficient way of accumulating knowledge. So next time, unfortunately, there will be a next time, we're in a much better position to tackle some of these questions than we have this time around.
Okay, so thank you very much for the answers. I think Miranda would be happy to have some closing remarks at this point.
Thank you.
Yes, this is the end of the plenary, the last plenary. So it means that it will almost come to the end of the whole conference. And that makes me a bit sad. I think it was a great conference. So I would like to close formally this session, the presenters, my co-moderator, Patrick, and I guess a family member. So thank you all all of you who attended the session, and the tech team. And then I give the word to Elaine for the very, very, very last words of the conference. Thank you all.
Thank you, Miranda, and thank you everyone from every session for the insightful, thought-provoking and really current presentations that have taken place over the last 3 days. It's turned out to be a fantastic conference. We were getting amazing feedback, so thank you all for all of the interaction. I'd also like to say a special thank you to Alison Smith, our conference project manager, who has worked really closely with the fantastic events company, Abby. Thank you all for all of the work that you've done, and also to the rest of the GIN team who are behind the scenes. So if we could put my presentation up, please. Thank you. So as a reminder, we announced that we were going to give out prizes for interaction during the conference. And for every 100 points that you received by taking part in the gamification, you would get a ticket which would go into a prize draw, and you would have the possibility of winning some cool prizes. So for the gamification, the first prize is complimentary registration to GIN 2022 in Toronto, a little less than a year away. So we're very excited about that. And this prize is going to Dr. Noriko Sasaki from Kyoto University in Japan. So congratulations and thank you for all the interaction throughout the conference. Our second prize is a £250 or about just over 400 Canadian dollars discount on an in-guide course. And this prize goes to Ms. Andrea Hickman from the Endocrine Society. So well done, Andrea. And again, thank you for the interaction. The third prize is complimentary registration for the in-guide level 1 course. And that goes to Professor Ayrton Stein. Congratulations, Ayrton. Our next prize is for the best poster. And the best poster will be displayed in the conference section of our website over the coming days. This prize has been nominated by all of you. So all of your votes have gone towards making the winner. So the best poster winner will receive, again, complimentary registration for the level 1 in-guide course. And the prize goes to Dr. Patrick Ockwin. So Patrick, you are winning this for your presentation, sorry, your poster on Evidence Tory Day, contextualizing knowledge translation and communication of evidence for consumers through storytelling in treatment of malaria in Africa. Well done, Patrick. And thank you to everybody who voted. So I am going to leave you there and hand over to the GIN chair, Zach Munn, who will give you some final words. Thank you, everyone, and until next time.
Hello, everyone. My name's Zach Munn, and I'm the chair of the Guidelines International Network. And I'm here to thank you all for attending our first fully online and interactive and engaging conference that we've ever held, really, at the Guidelines International Network. So thank you all so much for your attendance over the last few days. I do hope you've enjoyed the conference as much as I have. It's always hard to replicate the environment and atmosphere that you would get at a traditional in-person conference, but I really must take my hat off to all of the organisers of this conference and all of you, all of the attendees as well, because it has been such a fantastic experience, and it does feel like we have got to grow the network and get to know each other once again. So thank you all for attending this conference over the last few days, which I think has been a fantastic success. And this comes through in some of the numbers that we can actually see for the conference that we've just attended. We've had 500 conference delegates who have come from across the globe, representing 36 different countries, which is just an amazing effort, especially since it's been so difficult to get the right times for everyone to be able to attend. We have seen great attendance from so many people, and I think that's due to really the quality of the actual program that we've seen over the last few days. Both the plenary sessions and the concurrent programs, the workshops have been incredibly engaging and really pushing guideline methodology forward as well, and it's really stimulated a lot of discussions, I'm sure. we had over 260 abstracts that were submitted for this conference, which is a great result considering it is an online conference. And I just want to thank every single one of you who did take the time to actually submit an abstract for consideration or presentation at this conference. The concurrent program has been fantastic, and we've really enjoyed seeing you all present over the last few days. We've also had a number of really engaging panel sessions with some experts in the field sharing their experiences and once again discussing issues in guideline development, guideline implementation, and looking towards the future of guidelines as well. And all of these have been very rich discussions, and I'm sure you've all enjoyed them as much as I have. And we've also had some really practical workshops as well, and I've been impressed by how the presenters of all the workshops actually did engage and use the technology to engage as much as possible with attendees. And it was great to see that engagement as well. So a fantastic achievement by everyone involved, by the organisers, by the scientific committee, and of course all of you who have taken the time to come along to this conference and contribute to this program, either through your presentations or in your orals, or through your discussions and engagement with all of our sessions. So a big thank you and a big congratulations to all those involved. We couldn't have done it without you. And that does lead me into our formal acknowledgements for this conference. So I do really want to thank the scientific committee particularly, and in particular, the chairs of a scientific committee, Patrick Ockwin and Karina Schaefer, who have done a remarkable job in a relatively short time frame, I must say as well, to pull together such a wonderful and engaging and quite unique program. And I would like to thank Patrick and Karina and everyone involved in the scientific committee. I know that for some of you, there's been some late nights trying to get it all organised and sorted, and we really appreciate the work. And I think all that work has paid off with such a successful conference. I'd also like to thank the 2021 Conference Committee, which is a subcommittee of the GIN Board of Trustees, which is chaired by Duncan Service. And thank you, Duncan, for your tireless efforts in leading the Conference Committee and making sure that this conference was such a big success. We've also had a lot of people who put their hand up to volunteer and help us from across the globe to review all of the different abstracts that did come in many different areas and fields. And so everyone who volunteered on that abstract review committee, thank you so much for your generous use of time to help us out for this conference. I would also like to thank our external PCO team from Abbey for their support and expertise in this online conference field as we've tested the waters with our first fully online and interactive conference, and of course all of our plenary speakers who have done just such a tremendous job and really provided such interesting presentations. Thank you so much for taking the time to speak at our conference. And of course, we couldn't have done it without our sponsors as well, and really want to make sure that a huge thank you to our sponsors, our gold sponsors, EBSCO and Walters Kluwer, and also our bronze sponsor, the Registered Nurses Association of Ontario. We are really extremely grateful for your support, and like I mentioned, we could not have done it without our sponsors. So thank you so much for sponsoring this conference. I'm sure that a lot of the attendees enjoyed learning a little bit more about your work as well, and what you can offer also. And I look forward to our relationship in the years to come. So thank you, a huge thank you to our sponsors also, and to everyone who sponsored or exhibited at this conference. We really are extremely grateful for your support. And as one conference closes, we start to turn our eyes towards the future and to the conference for next year. And I won't speak too much about this conference because our Vice Chair, Holger Schoenemann, will be talking about this soon as well. But we are all really looking forward to the conference, which will be held in Toronto next year. And if you haven't already, make sure you mark these dates in your calendar. We can't wait to see you all, and hopefully, of course, in person as well, which will just be fantastic to actually see you all. This conference is being hosted by McMaster University and will be held at the Western Harbour Castle Hotel and Convention Centre, which is a fantastic location, and which is located on the shores of a beautiful Lake Ontario. So cannot wait to visit Toronto and to have this conference. So we are really looking forward to seeing you in 2022. It says here on the slides 2020. Well, it was originally planned for 2020, but we're so grateful and happy that we didn't have to cancel that conference. It's just been postponed to next year, and we still do get the chance to obviously go to Toronto for this fantastic conference hosted by, of course, the famous McMaster University, which are obviously really at the cutting edge of guideline development and the birthplace, of course, of evidence-based medicine and evidence-based healthcare. So I'm sure we will all be in for a treat at next year's conference. And what I'd like to do now actually is to invite the Vice Chair of the Guidelines International Network and the local host for next year, Holger Schoenemann, to tell us a little bit more about what we can expect in 2022 at the GIN conference in Toronto. So finally, just thank you all once again for your participation and contributions over the last few days. It's been a huge, enormous effort, and it really has paid off. So thank you all. Thank you so much for your engagement with GIN, and we can't wait to see you all at the exciting conference in 2022 in Toronto. And over to you, Holger, to tell us a little bit more about it.
Hello, my name is Holger Schoenemann, and as chair of the 2022 GIN Scientific Conference Committee and as vice chair of GIN, I'm pleased to reintroduce next year's conference in Toronto. The conference theme will address the important issue of making health choices transparent, equitable, and efficient. We will be exploring this theme across a range of important perspectives, including strengthening global guideline quality, technology, collaboration, and adaptation of guideline recommendations. The conference is being hosted by McMaster University and will be held at the Western Harbour Castle Hotel and Convention Centre, located directly on the shores of beautiful Lake Ontario. Toronto is a vibrant, multicultural city. It is the 4th largest city in North America and offers a tremendous amount of attractions. It is safe, and in particular, September is a wonderful season to come and visit and see our fall. We look forward to seeing you in Toronto 2022, and we hope that you enjoy our promotional video. Thank you.